Recently I've seen an increment in trend where a lot of the patients who are currently not my patients because I changed the country that I used to practice in. And I've known these patients when they were in their 20s and 30s. And it's been 10 years since I saw them, and they are now seeing a lot of mushrooming private psychiatrists. But there is a phenomenon that seems to be happening that needs legitimate inquiry. And I mean a moral inquiry, an existential inquiry, a scientific inquiry, and a wisdom inquiry, wisdom oriented inquiry that ought to happen because there seems to be this trend that these individuals I saw 10 years back, and a lot of them I didn't even prescribe any medications because what could be the best term to describe them would be some sort of an existential crisis or life issues, going through breakups, struggling a little, stumbling a little, but overall not quite meeting the threshold criteria for a serious mental illness. But now when I hear from them, they tell me they've been diagnosed by some other psychiatrist as being bipolar disorder. And it's incredibly saddening to me, and it seems to be happening way more than would be explainable by any rise in the prevalence and incidence rates of bipolar. That would be explainable by their life histories and natural cause of the illness of bipolar disorder, because it's unusual for people to have the onset of bipolar disorder in their late 30s and 40s. Um, and whilst that too is feasible, what is most peculiar to me and it stands out is that they have been diagnosed with bipolar based on sometimes just 5 to 10 minute interactions, and have been told in those 5 to 10 minutes that they are in an episode. And since most of these private psychiatrists do not really maintain any records, I don't even have things that I can read upon as to what was happening 2 years back or a year back. But from whatever little I can gather from the histories that the families and these people can provide me themselves, it doesn't seem to be amounting to full fledged episodes of illness which should be characterized as bipolar. The other confounding factor, of course, is that a lot of them have actually been on antidepressants when they shouldn't have been. A lot of them have been on antipsychotics when they shouldn't have been. Not only do psychiatrists seem to be carrying this dearth of understanding around what should be characterized as a manic episode or a hypomanic episode or a depressive episode, what makes matters even more complicated is the fact that sadly, a lot of these conventions are flimsy themselves. So, there are layers of issues here. The one, of course, is that I don't know how psychiatrists are diagnosing within 5 to 10 minutes of interactions. And even if those 5 to 10 minutes were enough for the episode to have been characterized as bipolar disorder episode, how in the follow-up duration, a lot of these patients have actually not even stuck to their medications, have not even stuck to their mood stabilizers, but still have been fine. How do you explain that? Two, what kind of interview techniques were used to establish that the person was actually having a bipolar episode? Three, was there a family history? Was there any alcohol use? When did the onset occur? Did it actually happen in 20s and 30s, or did it happen much later on? Four, are you really that much of an oracle that you can diagnose bipolar based on just few episodes? If so, why are records not reflective of the fact if it was a full-fledged florid manic episode or hypomanic episode? If so, what symptoms did you find? Why don't you have a record of that? And if you don't, will you be able to tell us what kind of episode was it? You see, in medicine, we used to learn about this concept of natural course of illness. So it's very unusual for a manic episode to come through, be florid enough within 2 days, and then just subside within 3 to 4 days or a week or 10 days. And even if such an episode happens, we have to really investigate it. Could antidepressants be the incriminant? Uh, whatever I'm saying, a lot of psychiatrists could come after me. She doesn't know what she's talking about. She doesn't seem to have a comprehensive understanding of things as they stand today herself, which will be fair criticism on their part if I were to put myself in their shoes, given they think that whatever it is, whatever little that we know about mental health and psychiatry is all that is there to be known. It doesn't work like that, and there are always outliers in terms of patients, and there are always facts that we ignore to be comfortable with the overarching truth that we want to percolate down into the community. I'm not really trying to talk in riddles, but sadly, brain is such an elusive organ, and everything to do with it is so elusive that sadly, no matter how hard I try to get across my point in articulated language, it's difficult at the end of the day because I have to say things as a professional, so it doesn't get characterized as complete misinformation, but also put doubts and lacunae where they fully belong. I have to also highlight the fact that you can't be diagnosing people based on 10-minute interactions. You can't be diagnosing people with a serious illness as bipolar disorder and not be sure if it was actually a spontaneous organic bipolar disorder, because there are ramifications of having to take the medication for the rest of their lives. It is disturbing to say the least, and I am just so affected by this trend. It speaks volumes about all the problems that are there in the world. First, why are psychiatrists being allowed to diagnose people based on 10-minute interactions? Second, why are records not being maintained? Third, can we really take a second opinion for a retrospective analysis if we don't even have records to go back to? Fourth, are psychiatrists really getting trained right? Fifth, are we becoming too obsessed and delusional and narcissistic about whatever knowledge is what knowledge is, and there's nothing beyond it? Because we can't be ignoring the red herrings. I do see people who develop serious side effects with antidepressants. I do see people who develop serious side effects with mood stabilizers. I do see people who, because of the psychotropic agents, the psychiatric medications that they have been prescribed, have had a cascade of events in their neurochemistry, which then has resulted in untoward incidents and untoward episodes, which then have wrongly been ascribed as full-fledged mental illnesses in their own accord. So we have to be very humble when we approach these amorphous islands of information and facts and try to make sense of it all in terms of some sort of a unifying, homogeneous, consistent, and sensible understanding of what mental illnesses are. And unless we embrace that humility, sadly, we are likely to commit far more errors and give patients far more burden of overprescriptions and over medication than really being able to help them. We have to be able to define suffering. What is suffering? What are we helping the person with? Is the help going to then lead to far more problems existentially, medically, to their bodies? And if so, have we done the effective risk benefit analysis or not? These are vital questions which can't just be thrown out the window, and it's high time we embrace these questions and not penalize a psychiatrist who is trying to bring these queries to the fore. Do I hope that that's going to happen anytime soon? No. Do I hope that it'll happen at some point? Yes. The threshold sadly would be when a lot of people have been harmed because of such practices, which are quite rampant in modern world. It is only then that humanity will wake up and rise. So do I know that I or people like me are only going to be demonized and seen as some sort of renegades? Of course, yes. But nonetheless, I have to say what I have to say. There are always trade-offs. There are always costs of being the first one to see things. And it's easy for the herd who believes that the journals and scientific journals and scientists know it all, and we've been able to dig up all that was needed to be dug up about mental health and psychiatry. And this is a woman who seems to be deficient in knowledge, and that's why she's saying what she's saying. Do I expect that to happen? Yes, that's a trade-off for being the one who sees. But That's all right. The trouble, though, is what these so called critics wouldn't understand is that I can debate with them on the established literature. I know what is established, but I'm trying to look out of the parapet and trying to comprehend things beyond what is already established as science. And the thing is that it doesn't require a great deal of intelligence and wisdom to be able to do that, because if you really look at your own patients, you will see there's so much that just doesn't fit into what is being taught to us. And so that can't be an anomaly, that can't be ignored, that has to be subsumed into your knowledge base, that has to be subsumed into some uh, legible lexicon that you could use to make sense of a hypothetical model of what is going on in a person's brain that causes them to have the presentations that they do. And this bipolar disorder example stood out as a very pertinent example because it was rather agonizing to me that lately I saw so many people coming back to me who have seen 10 years back, and that should have been the onset of bipolar disorder because, when you look at the natural course of such illnesses, they do not tend to happen so much later in life. They can, but the way they are becoming so rampant and how it is being deduced is for sure worrisome.